Hello and welcome to the Osteoarthritis Action Alliance Lunch and Learn webinar for January 18th, 2023. Our presenter today is Dr. Francis Keefe. Dr. Keefe is a professor in the Department of Psychiatry and Behavioral Sciences, professor in anesthesiology, and professor of medicine. He is also director of the Duke Pain Prevention and Treatment Research Program, an active NIH-funded clinical research program focused on developing new and more effective ways of assessing and treating patients having acute and persistent pain. Dr. Keefe played a key role in the development of clinical pain services and pain research programs at Duke Medical Center. For over 20 years, he has directed the pain management program at Duke and was a leader in the development of Duke Medical Center's multidisciplinary pain programs, both outpatient and inpatient. Dr. Keefe has developed and refined a number of treatment protocols for persistent pain conditions, for example, pain in patients with advanced cancer or persistent joint pain due to osteoarthritis, including spouse and partner-assisted pain coping skills training interventions. He has conducted a number of randomized clinical trials testing the efficacy of these and other behavioral interventions, such as aerobic exercise protocols, yoga-based interventions, mindfulness-based interventions, forgiveness-based interventions, loving-kindness meditation, and emotional disclosure. Dr. Keefe has published over 450 papers and 4 books on topics ranging from pain coping strategies used by people suffering from persistent pain to the treatment of cancer pain at the end of life. For the past 10 years, he has served as editor-in-chief of Pain, the premier journal for publishing basic and applied pain science. Dr. Keefe has a long-standing interest in mentoring students and early career professionals who seek to develop, test, and disseminate novel protocols for pain, stress, and medical symptoms. And Dr. Keefe's presentation today is titled Coping with Arthritis Pain, What We Know and What We Need to Learn. Dr. Keefe, I will now turn it over to you.
Thank you so much. And it's a delight to be here. And I'd like to thank all the participants for joining us, either for their lunch or other nourishment as they watch. I know that many of you have very, very busy schedules, so I appreciate you taking the time. And I'd also like to thank the patients and caregivers who have participated in some of the studies that I'm going to be talking about today. They've actually, many of them very selflessly participated and contributed important knowledge and updates to our understanding of pain and how people deal with it. And finally, I want to recognize many foundations and the NIH and other funding agencies in other countries that have really supported this type of work. Without this funding, many of the advances I'll talk about today would not have occurred. By way of overview, I'm going to start by talking about what we know about pain coping, highlighting some of the conceptual issues in the field. And then I'll move on to what we need to learn, so a couple of key questions that need to be addressed, and then some final conclusions and clinical implications. So what we know about pain, I've been in this privileged position as editor of Pain of really seeing the landscape. And it's pretty incredible when you think about what's happened to pain science over the last 10 years. You know, we've really evolved from this very simplistic understanding of pain as a simple sensation that really dominated the field for many, many years, came about as a result of Descartes' thinking in the 17th century, but continued to have a major impact. And really, more recently, we know much more about how pain is processed in the brain. We know that changes in the spinal cord related to central sensitization can be a major contributor of pain. We know a lot more about the molecular players in pain, and so on and so forth. And I want to highlight in particular, because it provides a nice context for the work on pain and coping, some of the work that's being done in brain imaging. And in these brain imaging studies, participants who volunteer are put in a scanning device, and scans are taken of their brain either at rest or while pain stimuli are being delivered. And if you look at these studies, while simple pain stimuli, acute pain stimuli are delivered, one of the fascinating findings is illustrated on this next slide, that you not only get lighting up or increased activity in areas of the brain that we classically think of as involved in sensation, but we also see many other areas of the brain being activated. So areas of the brain related to attention and emotion and motivation, pain control, stress, and so on. And this has been called the pain connectome to basically underscore the notion that pain is processed in a distributed fashion across the brain. And this is interesting because we're talking about fairly simple, brief, acute pain stimuli. And of course, the question that arises in the context we're talking about today, osteoarthritis, what happens when pain persists? And there's been some fascinating recent findings about this. So when pain goes on for quite some time, one thing that we begin to see is more and more connections between these different areas of the brain that I've talked about. These connections get stronger, and we see a movement from a lot of activity just in the sensory area to increased connectivity and increased involvement of those networks in the brain related to emotions, related to cognitions, related to pain control, and even reward processing. There's some very interesting data on reward processing and pain, which basically says that individuals, as they develop an inability to update expectations of a reward. So maybe somebody's learned time after time, if I do this activity or engage in this behavior, my pain's going to get worse. If their condition changes, people that have difficulty saying, oh, maybe I could do that now and not have pain or as much pain occur, people that are prone to that tendency are much more likely to develop persistent pain. So these markers listed on the bottom right here now are seen as potential risk factors. The more the brain shows this tendency these tendencies to involve the emotional centers, the cognitive networks, and so on, the more likely someone is going to be progressing to persistent pain. Absolutely fascinating. And I guess the bottom line here is this brain imaging work really makes the point that, you know, our thoughts and feelings and behaviors really matter. So a patient's beliefs about their pain, their judgments in response to a particular pain episode, the memories they have, the images that they may have of themselves in the future, their expectations, certainly their emotions, depression, anger, and their behavior patterns. Many people, when they develop persistent pain, learn that avoidance helps them out, and the avoidance can build on itself. They might actually get isolated. And as I've already mentioned, there often are deficits in engaging in newer behaviors, even though pain is in the picture. And so the problems with reward processing and learning that occur are important aspects of the behavioral adjustment to people that people make to pain. So I emphasize this work because it's more of a basic science perspective that really connects so well with this coping perspective I'm going to talk about today. Because many of the things we'll be talking about in terms of coping are related to what's happening in the brain, some of the things I've just talked about. Now, this early work on coping really came out of, you probably remember the studies Hans Selye did in the 1950s with animals, basically showing when you delivered a stressor, and he often used pain, that you would get a reliable physiological outcome. So reliable, he labeled it the general adaptation syndrome. It was seen time and time again in different types of animals. And there was almost a kind of dose response relationship. If the pain was more severe, you get more of this adaptation response. If it was less severe, less. If it occurred more frequently, and so on and so forth. And this work was very interesting to people working in human studies, and particularly people that were studying individuals with persistent pain. And investigators reasoned, oh, we can use the stress and coping model to really understand how people respond to events when they have persistent pain, such as a pain flare. And they predicted that if the pain flare was longer lasting, if the pain experience was more severe, then you'd receive then you'd see a corresponding increase in the disability and distress and dysfunction and so on. And if it was less severe, correspondingly less. So the anticipation was a kind of, again, dose responsive relationship. And what emerged, and this won't surprise any of you who are clinicians, is something very different. That in fact, study after study showed these incredible variations in outcome in people with persistent pain to a pain flare. And one person seemed to be able to weather the pain flare, engage in their regular activities. The other person would be really impacted in a very major way, might have to go to bed for several days, take increased pain medication, and so on. So these variations have shown up time and time again in research studies and clinical observations and so on. And this work got people thinking about different models of coping and stress. And to explain these variations, people began to turn to a model that Richard Lazarus came up with called the stress and coping model, which, even though it's an old model, is continue to have an incredible impact even up to the present day. And what Lazarus said is basically, we're talking about individuals who are trying to make sense of what's going on in their environment. So they're having a pain flare and they're making judgments. Whether this is something benign, maybe I've been through it before, whether it's really very threatening, it's a signal that maybe their disease is progressing, and they're also making judgments about what's coming on. And depending on those judgments, you'll have varied outcomes. And there are different types of appraisals they've talked about. So the first one might be, what if the person sees a pain flare as evidence of threat or loss? They're judging it, I can't cope with this, there's nothing I can do. They're having this image of ending up in a wheelchair. And the more they get caught in that type of thinking, they get certain outcomes, like they're more fearful of the pain, they're more depressed, they're avoiding situations, they're irritable and isolated, and so on. In contrast, someone might see that pain flare, again, based on their experience and so on, as more of a challenge. They may be thinking to themselves, this is going to be tough. I've been through this before, but I know there's some things I can do to manage it and get through it. And you can see that these different types of appraisals might result in a different set of feelings. Person's concerned, maybe they're somewhat anxious, but they're confident they can deal with this, and maybe they start pacing their activities because of that appraisal. So all this is to say, appraisal and coping are very, very important. And this is a model that spurned a lot of research, which we'll talk about in a bit. But I just want to update some of the recent approaches to thinking about this stress and coping theory of pain. And one thing that we now know is that although Lazarus emphasized conscious judgments that you're making as part of appraisal, we now know that people actually, even before they're conscious of the situation, they're processing the information that's occurring. So this appraisal can occur very rapidly out of consciousness and bias you to a particular set of conscious appraisals. So that's kind of an interesting finding. Secondly, we know that there's a process of reappraisal, so that as you appraise the situation, let's say you're appraising it as a challenge, it's just tough, there's some things I can deal with it. The outcomes that occur, so maybe you're finding, if I pace my activity, I'm still having some pain, but it's not, the flare seems to be resolving better. And so that the engaging and coping efforts that are triggered by appraisals lead to outcomes that get you to reappraise that even more as a challenge and something you can deal with. And the third thing, and this is probably, again, familiar to any of you who are clinicians or have kept up with this literature, there's more and more evidence that early experiences, exposure to trauma, certain personality traits, the environment that someone's in, their genetic background, can again bias people towards certain types of ways of appraising and so on. They don't fully determine appraisal, but they're factors that influence it. So the bottom line of all this is that the way we appraise stressors like pain flares really do influence and trigger our coping efforts. And some examples of different strategies that people might use in response to these appraisals, they might do things like pace their activities that I mentioned. They might, For example, while they're having pain, try to relax more than they might at other times. They might seek support from others, or they might engage in cognitive strategies, trying to distract themselves or calming themselves in response to overly negative thoughts and so on. And there's a question of some of these strategies more effective than others. A very interesting community study looked at both passive coping strategies, such as avoiding activity and resting, and active coping strategies. And this community study found actually that passive coping was more likely to be related to pain-related disability and healthcare visits, whereas active coping had the opposite effect, a reduced likelihood of pain-related disability. So it does appear to this more active approach, which is now very much emphasized in the treatment, particularly of persistent pain, can be beneficial for many people. What about measuring and modifying coping? Can we actually measure these different types of strategies in a reliable and valid fashion? And research does show there's a variety of instruments that have been developed and they continue to be used. They get at different types of strategies, active versus passive, cognitive versus behavioral, and so on and so forth. And these are varying lengths from, they might take a patient anywhere from 10 minutes to 15 minutes to complete. And more recently, we've seen very brief coping measures developed that are being integrated into clinical practice and also integrated into national surveys and epidemiologic studies. And these very brief measures really have benefits because they can actually be used in your smartphone, they can be used in tablets to capture on a daily basis how people cope with their pain, and also pain-related process such as the pain severity itself, things like depression or anxiety. So you can look at how pain coping and pain track over time. And you can certainly imagine a clinician looking over those patterns and making certain judgments about what the patient might benefit from. We also know that these measures, both the brief measures and the longer measures, relate in meaningful ways to outcomes. So for example, not surprisingly, the way you cope, the way you appraise pain relates to the severity of pain, but it also relates to directly observed pain behaviors. If you look at how much people are using guarded movement, showing facial expressions of pain, these forms of coping and appraisal relate meaningfully to that. They also relate to psychological distress. They relate to physical disability, such as performance measures, and behavioral outcomes, such as medication intake and recovery from an injury or a surgery. So these measures do seem to have utility in increasing our understanding of these variations and how people adjust to pain. And as I mentioned before, the more active coping strategies do seem to relate to better outcomes. We also know there's a large body of literature showing us that pain coping can be modified. So there are standard protocols using either behavioral techniques or cognitive behavioral therapy, mindfulness-based stress reduction, acceptance and commitment therapy, and there are others that take as their targets altering how people are making these judgments of pain and how they're coping. And the research shows that, in fact, it can alter those appraisals and coping. And furthermore, it can improve outcomes such as pain and psychological distress and physical disability. So these protocols are interesting and have been shown to have efficacy. What do we need to learn in this area? I'm going to highlight just a couple of things. So one is the social context of pain. When people are living with a painful disease like osteoarthritis, they don't do so in a vacuum. They typically are interacting with others. They may have a partner, they may have a spouse, and so on. And one of the questions that has arisen, can we take advantage of this social context? Now, to think about the social context, we need to know it's very stressful for partners. And there's been some interesting imaging work, again, done of people being shown images of their loved one in pain. And what that work has shown is that seeing a loved one in pain activates the very same brain areas involved when you yourself experience pain. And these are called mirror neurons that get activated. And interestingly, if you happen to be more empathic, you're going to see more activation of those neurons. So when you're caring for another, trying to help them cope, you're dealing with a lot of challenges, but one is that it may be arousing things in you that make your task of helping out difficult. And there have basically been two types of interventions that have been used with osteoarthritis and diseases like cancer that involve patients and caregivers. So one approach, and this is Dr. Laura Porter at Duke, who's done a lot of work in this area, is to do what's called partner-assisted training in pain coping skills. So in that situation, the focus really is on the patient. The target is helping the patient learn coping skills, and the partner is really there to be a coach or assistant, encouraging the person, helping out, learning the skills in the service of helping the patient. And there's evidence that this approach can be effective when compared to a control condition where the partner is also there, but they're not trained in these skills. Another approach is actually to take the couple as the unit of focus and to say, well, you're both in this together. Let's try to work on things to help you as a couple deal with this. So things like communication and the way you problem solve and interact. And that's another way to try to help people who are dealing with a painful condition. And you can imagine the benefits of this, and these have been shown in studies conducted in this area, that both partners have a better understanding of pain and the role that medications and other things can play. And the partner may be much more able to encourage and reinforce the patient's effort, and enhances the partner's sense that they can do something in this situation. And many partners feel sort of lost in this situation and don't have much confidence that they can help. Another problem that is receiving a lot of attention is we got these protocols for helping people modify their pain coping, but very few people ever receive them. Many of them involve travel to work with a CBT specialist or something like this. And this has led into a whole raft of studies across the world, actually, and looking at novel ways of enhancing dissemination of these approaches. And we have video over internet. We have the train the trainer approach, or working with other healthcare professionals, phone-based interventions. And there's been a host of studies developing internet-based training and apps to help people learn how to cope with arthritis pain and other types of pain. And some work, just to highlight some work we're doing here with cancer pain. Tammy Summers in our group has been looking at a tablet-based approach to working with patients. And one of the real advantages of this approach is not only can you interact like a therapist with the patient, or in this case with couples around this, but you can also observe them interact in their daily environment, like in the kitchen or climbing stairs or working in the garden, and actually coach them how to apply the skills they're learning as they're doing these tasks, simply by turning the pad around and turning the camera onto the patient as they do these activities. And what a wonderful way to teach people to apply skills that they've learned. This is an internet program. If you're interested in internet programs, we have developed one that's available. You can Google Pain Trainer, and you or your patients can use this for free. And this has been tested in a variety of studies conducted in our lab, and is now being the focus of studies conducted through the HEAL network. But many of the early studies we did with this 3 RCTs are with osteoarthritis pain. And this is just one of the examples of, we have a coach that talks patients through this, so they don't even need to read the important material that's presented here. And we have various interactive tasks. So we ask them, we taught you some brief relaxation, where are you actually using it? And they can compare what they're reporting on that to other people and how effective it is to other people that are using the program. So I know this has been a bit of an aerobic talk. I hope you're still hanging in there. But just a few conclusions. So one is, we do know that pain coping and appraisal can be reliably measured, that there are brief measures that you could incorporate if you're doing research or clinical work, that looking at pain coping and appraisal can actually help us understand these individual differences I've talked about. And that I think folks need to be aware that there actually are interventions that can alter pain coping and appraisal. And these not only reduce pain, but if you look at the meta-analyses, also have significant effects on psychological disability and one's physical adjustment. And I think one of the most important directions are these new strategies for extending the reach of these interventions and other approaches to enhance treatment effects. So I'm going to stop there, and I'll take any questions at this point.
Thank you so much, Dr. Keefe. That was wonderful. I specifically really loved your highlighting of the psychosocial aspect of pain, and sort of how that has such a key role in pain coping and, how people are able to deal with that. Just to get started, we do have a couple or time for a couple of questions. And just a reminder, feel free to type any questions you might have in the chat box. Also, in a few minutes, you will see a poll pop up onto your screen with some survey questions. So if you could take a chance after we finish with questions, if you could just do that before you leave the webinar, that would be wonderful. And it does look like we have a couple of questions. Susan is wondering if you could comment on the value of using a pain diary, if you know anything about that.
Yeah, so these brief measures I talk about are typically incorporated as part of a pain diary. And I think pain diaries can be very helpful. I think it's very important, though, when you keep a pain diary with a patient, not to simply be recording pain severity, but I think you want to also look at some adaptive things that people might be doing to deal with their pain, so you can see how they relate. So you might be looking at daily exercises they're doing. You might be looking at goals they had for the day and how they're completing those. You might be looking at certain coping strategies that they're prone to use, such as the use of meditation or positive self-statements, different things they might be doing. And I think by looking at that relationship, you begin to have opportunities to see how things fit together. And you could see the impact of a pain flare on the kind of adaptive behaviors that we talked about. So I think it's very important. In many of our studies, we've actually had OA patients fill in diaries 3 times a day for 30 days before treatment and 30 days after. And patients have told us simply keeping that diary as part of the research study was very therapeutic.
Yeah, that's great. Thank you very much. Another question we have is, what are some questions we can ask clinicians to figure out what kind of appraisal strategies patients can use?
Yeah, I think asking people what is going through their mind. I think a pain flare is a really good one to focus on, and we use it clinically. So we ask people, we give them, a scenario. You probably know what a pain flare is. You probably have had one. One of those times that the pain really increases and it's going to be there for a while, and get them to simply articulate. You could even get them to imagine they're having it for a moment, just 30 seconds focusing. Get them to articulate what's going through your mind. What are the thoughts that you're having? What are some of the feelings that are happening? What images come to mind when you do that? And it's amazing when you do this, that people who often are considered non-psychologically minded will begin to really explain and illustrate their typical responses to these. And you'll begin to see these patterns of, someone saying, I've had it enough that I kind of know what's going to happen. And I know it's probably going to last half the day. And there's some things that maybe I'll temporarily reduce my activity. And other people, they're immediately going to, oh my God, I know I'm going to be laid up for, 3 or 4 weeks. It's going to be terrible. I know the medication isn't going to cover it. I just start to get anxious as soon as it starts to happen. So you see these incredible variations. And one of the things is asking people, well, when you get caught in that thinking, whatever it might be, how is it working for you? Is it helping you, or is it kind of working against you? And often just asking that question, people begin to say, actually, I think that probably makes me worse when I think that way. And that provides an entryway to beginning to get them to think about, would there be a different way? Knowing that it's severe and it's tough to deal with, is there a different way to be thinking and judging that event?
Great, thank you. I have another question that's saying this sounds like an area that occupational therapy could really focus on. How can you see this expanding into OT or PT treatment?
That's a wonderful question. And I think occupational and physical therapy have so much to offer in this area. It's very interesting to ask me that question, because at Duke, the head of occupational and physical therapy came to my group and they said, so many of our therapists are taking weekend workshops and 3-hour workshops, online things, to learn some more of the psychosocial kind of psychologically informed approaches. And the problem they're having, they learn some of it, but it's really applying it in practice. And is there something that you could do? And we've actually developed a program where we bring people in weekly for 12 weeks to train them experientially in these different techniques. So they actually get to practice it themselves. And then that's followed by 12 weeks of very small group supervision to working with OTs and PTs. Might be 4 to 6 that work with kids, 4 to 6 that work with older adults, stroke patients, whatever, to take what they've applied, learn and actually apply it with patients. And this has been wonderful. We've now trained all 300 of the OTs and PTs at Duke in this approach, and it's been wonderful application. We have champions in almost all the inpatient and outpatient units now, but they have so many more opportunities than a psychologist or a mental health professional would have to apply this. And often they're applying it early in the course of someone's pain rather than when we get to see them very, very late on. So I think that these are techniques that can be expanded to many health professionals, can be integrated, even little brief interventions could be integrated into many types of clinical practice and could be very beneficial.
Wonderful. We have more of a general question about how to deal with localized joint pain.
No, that's a really good question. And certainly in our studies of OA, we had patients with multiple pain sites, but many of those individuals had pain in a very localized site. Again, I'm talking about chronic pain. These are not people in our studies, they're old, usually with osteoarthritis, older adults, they've had the pain for some time. It's not like they just had their first knee injury and, you know, they were a teenager or something like that. So we have found that we have not seen a difference in treatment outcome, teaching people these coping strategies, regardless of whether their pain is localized or generalized. We know we haven't seen that pattern. If you really wanted to apply this in the acute pain setting, there are people now who are working in the emergency department setting, looking at, can we teach people or at least link them up with training programs following an acute injury to better maximize our impact, so that it's not just, let's say, a prescription for an analgesic or an anti-inflammatory agent, but it's that coupled with some of these types of recommendations that I've mentioned. And so that's a really interesting area for future work.
Great. We're wondering if there are any comments, or you have any comments about managing pain before you have it, like tracking triggers or being preemptive in that way.
Yes. So this is obviously important in people who have episodic pain. And again, it gets back to the question on the pain diary. It can be very, very helpful. And what we've often seen in these situations is something happens in the person's life. You know, their spouse becomes very ill, or an illness of a child, or they lost a job and their routine is interrupted. And then what follows that often is often increased emotional distress. And then secondly, people stop using things that were part of their life, you know, exercise. You know, they're no longer walking in from the parking lot. They're not having the pleasant social interactions that they were having at work. So many of the things that were part of a healthy lifestyle, maybe eating, you know, when they would go out at work, they were going for healthy food rather than fast food. Those things begin to drop out. And then you see they're more vulnerable to, if they have a pain episode, for that being more devastating. So I think that a lot of what we're talking about are kind of life skills, and people maintaining healthy life skills as a way of preventing pain. And ultimately, I think, you know, we're seeing primary care go in this direction of emphasizing healthy behaviors. And ultimately, I think in school, in grade school, junior high and high school, we're going to see more and more emphasis on this as an important part of living. And one could even imagine, you know, courses, and I think there are some, in healthy living, things you can incorporate into your life pattern that can prevent some of the problems that we see.
Wonderful. We have one more question, and you will also see that the poll has launched. So whenever you get the chance, if you could take that. But our last question is about recommendations for patients that have had a hip replacement that now have joint pain.
Yeah. Well, what's interesting, and this was actually, I was asked to provide some questions in case there weren't any questions today. And I think one of the striking things that's emerged, I've kept up with the literatures on how people deal with the different types of disease-related pain at end of life. And one of the interesting things is that the approaches that one would use from the perspective that I'm talking about, the coping perspective, and the assessments that one would make are very similar across different pain conditions and pain situations. So I guess the answer to that, I think, would be a very similar approach of trying to understand how that person copes with their problem, looking at, often what I do is very helpful clinically, is just go through their typical day with them. And as I go through the day, pinpointing strengths, and so I'm thinking about thoughts, feelings, and behaviors that are strengths, and then particular problem areas. And I find when I do that, and I push them, I'll take 15 minutes at least to go through the day. When you're there and you get up, who's around? What do you do? What's working for you? What's problematic? You begin to see a pattern emerge. And so if you have somebody with this joint pain and they've had a hip, you're probably going to get a better sense of how it's affecting them, things that they're doing that are helping, that are working against them. You may have some ideas if you know about skills that people can use to manage pain, certain skills that they might benefit from. You might then link them up with either a therapist that can teach them that, or some type of online program that teach them that. So I guess the bottom line is that many of these patterns of appraisal and coping are similar across lots of conditions, and variations on these strategies for modifying pain and coping can be therefore beneficial for many different people.
Awesome. Well, thank you so much, Dr. Keefe, and thank you everyone for attending. That concludes today's presentation. Please feel free to join us next month for our February 15th Lunch and Learn featuring Molly Minning and Yvonne Golightly, who will present on investigating the barriers and facilitators to the adoption and implementation of injury prevention exercise programs. Thank you again.
Take care.